Positioning of the patient on the surgical table is intended to optimize access to the surgical site, while avoiding complications that may arise as a result of the positioning. Safe positioning is the responsibility of all members of the OR team. The movement and function of the surgical table, as well as the coordinated actions of OR personnel, and the attachment and use of surgical table accessories, such as an arm support, will be discussed in this film. Several types of accessories exist to aid patient positioning. A few examples will now be mentioned. As the name implies, the head support is used to support the patient's head and prevent pressure complications from developing in dependent areas, such as the skin over the occiput. Other accessories used to prevent pressure complications include gel wedges, which are used when the patient is placed in a lateral position. This accessory has a groove for the dependent arm. Also of note are gel pads, which are used to protect the skin and nerves of the arms. Other accessories that may be used are body supports, used to support the pelvis anteriorly and posteriorly when the patient is in the lateral position. The patient's legs can be positioned in a variety of ways. Stirrups are used when the patient is placed in the lithotomy position. This particular set of stirrups can be adjusted to allow different degrees of flexion of the hip. These are but a few examples of accessories that can be used to ensure safe positioning of the patient. For a more detailed elaboration of the surgical table and use of its accessories, refer to the course Surgical Table. Their use as well as the use of other accessories will now be discussed. Typically, patient positioning begins with transfer from the patient's bed onto the surgical table. If the patient is unable to transfer themselves, 4 members of the OR team are required for the transfer. The actions of the team are typically led by the person at the head. In many hospitals, this transfer leader is anesthetically trained. They have responsibility for ensuring that spinal alignment is maintained during the transfer, and are also responsible for the patient's airway. Take note of the transfer rollerboard, which is used to slide the patient from the bed onto the surgical table, as well as the draw sheet, which can be used to adjust the patient's position once safely on the table. At the direction of the transfer leader, the patient is first rolled onto their side, with this team member positioning her hands at the patient's hip and shoulder. With 3 team members turning, the 4th team member positions the rollerboard underneath the patient, as now shown. With the transfer leader giving direction, usually by way of counting, the patient is transferred onto the surgical table. Once on the table, the patient is once again rolled onto their side and the rollerboard is removed. Take note of how the team members positioned next to the surgical table maintain their position close to the table, preventing a potential fall. The other operating room staff move the bed. With the bed moved and the patient in supine position on the surgical table, they can now be placed in a number of positions. The supine position will be discussed first. In this position, the head is placed on a head support as shown. The arms can be pronated as shown, and the patient slightly rolled away from the arm, and the draw sheet then tucked in between the arm and their body. This is done with care to avoid creases which may cause pressure complications. Care should also be taken not to dislodge IV lines. Alternatively, the patient may be positioned with their arm abducted away from their body. An arm support is attached to the surgical table. The OR team member then places the patient's arm on the arm support while making appropriate adjustments to ensure patient comfort and safety. With adjustments completed, take note of the angle of abduction. This angle is kept below 90 degrees to avoid stretching the axillary nerve and potentially injuring it. Take note also of how the arm is kept in supination, preventing potential compression of the ulnar nerve at the medial epicondyle. A further protective measure is the placement of a gel pad between the arm and the arm support. Safety straps are then used to secure the arm to the arm support. In this position, the heels are also at risk of pressure complications. For this reason, a gel pad is placed between the heels and the surgical table, as shown.